So there's my one disclosure. You know where I come from, Georgetown University for 20 years, and was the director of the heart transplant program. And after retiring from doing cardiac surgery after 20 years, I focused on critical care at George Washington University and now Johns Hopkins University. And I did create a nonprofit foundation that's dedicated to the multidisciplinary approach to critical care, to the critical care of heart surgery patients. And so we just had our 13th annual conference, and we're working on the 14th. Well, renal failure after cardiac surgery occurs in medical centers around the world. And as you well know, it is well known that there is an acronym, CSA AKI, Cardiac Surgery Associated Acute Kidney Injury. And as I say, 10 years ago I was here when we had an AKI dedicated to this, and then followed that with the cardiorenal syndrome, which of course is related. But we have an expanded challenge in cardiac surgery. The patients are older, they're more acute, there's an increased complexity of procedures with multiple reoperations, multiple procedures within an operation. There are coagulopathies now, especially with clopidogrel, aspirin, and the various antiplatelet agents. And now there's a need for open chest protocols and new supportive technology. Here is an open chest protocol. You know, we've had the presentations today about the accumulation of fluid overload. Well, that happens in cardiac surgery, and especially with the prolonged cardiopulmonary bypass time, sometimes we simply have to keep the chest spread, and there's a way to protect it from the outside, and this is an example. But that is an issue in taking care of cardiac surgery patients. Also, you know, we now have mechanical assist, left ventricular assist devices. We've had a paper come from here, from Vicenza, related to the risk of AKI and that. And then we also have extracorporeal membrane oxygenation, ECMO, and we couple that generally with renal replacement therapy. And I think you can see that we have a RRT machine as well as a ventilator and the cardiopulmonary bypass support system. Well, what are the risk factors for AKI? You know, there was an excellent study from Milan in 2004 that looked at 5,000 patients, and it was very clear that the mortality was considerable, that if the patient developed acute renal failure, the mortality was 41%. If they required renal replacement therapy, it was actually above 50%. And that corresponded with what was seen in centers around the world, including the Cleveland Clinic. The multivariate analysis showed, and this is not surprising, that blood transfusion, elevated creatinine, emergency surgery, reopening the chest, low ejection fraction, they were all, and mitral valve disease, all associated with acute renal failure. And if you looked at whether renal replacement therapy was needed, they were the same basic parameters, and you'll see duration of cardiopulmonary bypass is an important factor. Now, this is an excellent paper that came out in Blood Purification from Hayes and Felix, and about the perioperative hemodynamic instability and fluid overload. We've talked about fluid overload here a good deal, are associated with increased acute kidney injury and worse outcome after cardiac surgery. And so just summarizing, this is an excellent paper. The point was that after start of anesthesia to 24 hours after cardiopulmonary bypass, if norepinephrine is needed, if the norepinephrine goes to the highest dose, the lowest mean arterial pressure, milrinone, lowest cardiac index, these are all risk factors for CSA AKI. Now, what about the latest incidents? Well, here's a study from Stanford published in the Annals of Thoracic Surgery. This was basically, you can see 2,952, 528 cardiac surgery cases, 3 million cases. And you can see that it did show improvement. This is over they had 2 periods, and it ended in 2008. And the mortality did come down some, and the AKI risk came down some. But I think in centers around the world, most places say that it's probably the AKI risk, if renal replacement therapy is necessary, is about 40 to 50%. Well, we have a study here from Hobson, from Florida. And this, I've quoted this study a number of times along the way. And this is important about what is the long-term effect. Why are we so concerned about treating cardiac surgery-associated AKI? And this study defined it very well, that based on the class of AKI, that the mortality, if you look at the 10 years, look at that, well, 40% or less than 40%, if it ends up in failure. So clearly, this is an important venture that we're on to try to decrease the incidence and prevent it. And so CSA-AKI impacts mortality, length of stay, and complications, including lung failure, infections, and GI complications, and deep venous thrombosis. This is a paper from this institution about renal replacement therapy, and the point here is that early RRT, at least in a review of the literature, is usually considered to be associated with improved outcomes. Continuous RRT is preferable to intermittent RRT, and truly is the standard of care in critical care units, and then the importance of citrate anticoagulation. Well, this is a study about the early versus delayed initiation of renal replacement therapy. Single study. You recognize the authors here well. And the point is that there is an important, if one recognizes the need for early renal replacement therapy, there is an important decrease in the mortality, as you can see. So early diagnosis remains a continuing challenge. And you know, in the past, as you well know, the diagnosis in the past has been delayed because we based it on a rise in serum creatinine. And you probably know that the pump prime, if a patient's put on cardiopulmonary bypass, the pump prime is generally a plasma-type solution. And so it dilutes the serum. And in fact, serum creatinine right after cardiac surgery is considerably less than it was when we started. And if there is AKI on top of it, clearly we don't recognize that AKI has occurred for about 48 hours. So late recognition has led to late institution of potentially effective therapies to mitigate the effects of AKI. So a fundamental issue during cardiac surgery and postoperatively are the ongoing hemodynamics causing AKI. And you see, we have ways to at least address AKI if we recognize it's occurring. We can optimize cardiac output, flow on cardiopulmonary bypass. We can adjust the renal perfusion pressure, and we can create an optimal AV gradient, and we can avoid nephrotoxic agents. So there are ways we can address it, and a number of the presentations have shown that institution of protocols can impact the incidence of AKI. And then fundamentally, from a cardiac surgery standpoint, when I talk to the fellows and the residents, I talk about the 6 basic parameters that we have at our bedside. We have heart rate and rhythm. We can adjust the preload. We can adjust the afterload. We can adjust the contractility. We can adjust ventricular compliance. You all have levosimendan, but we don't have it in the USA. But it is also, that will affect ventricular compliance. So that's an advantage you all have here. And of course, very importantly, and as a surgeon, I always had in the back of my mind, and I was taught by my mentors, always consider, is there something happening now that you didn't anticipate? And is there something you need to do? For example, cardiac tamponade? Do you need a mechanical a device? So in the back of one's mind, one always has to say, maybe it's not quite as good as we think it is, and especially if things are marginal. So very importantly, and I think it's been stressed here, that every patient is a unique individual with unique hemodynamic and oxygenation requirements. And you see, these are the classical parameters, but you'll notice that there are ranges. Look, mean arterial pressure in 70 to 90. Now, we talk about 70, 80, 60, whatever, but it depends on the patient. Do they have vascular disease? Do they have cerebral vascular disease? Do they have atherosclerotic disease in their aorta? Do they have renal artery stenosis? There are a whole range of factors. And then, of course, the right heart as well. But there are confounding factors that we've learned over the years. For example, blood transfusions do carry a risk of AKI. And they, and we know that that blood transfusions are to decrease them, to reduce them is important, because we can reduce acute lung injury, reduce infections, and reduce AKI. So, but the problem is a need for vasopressors. So I can tell you, working in the unit, if the hematocrit goes down to let's say 20, why there's a greater need for vasopressors. And the question is, how is that affecting renal blood flow? Well, what criteria in real time do we have to optimize the balance of hemoglobin level in vasopressors? Now here is an important paper from Italy, and this has been a guide, frankly, to us at Johns Hopkins and I think to others, that in fact hemodilution does carry a risk of AKI. And so these investigators designed a protocol over time where they actually adjusted a number of factors, and it's a very good paper. I recommend it to you to read about the factors they adjusted. But you see, what they noted was in their first series from 2000-2007, that you can see that the lower the hematocrit was, the greater the risk of AKI. So if you move over, go to the left, when that hematocrit was 20, you can see the important risk of stage 2 AKI. And you see, then when they adjusted their protocols, they actually, in that next period of time, the next 5 years, they were able to reduce their incidence. And of course, we've talked about, Dr. Ronco presented a protocol, for example, that is aimed at achieving the same type of effect. So what is a goal-directed perfusion protocol? And this was the protocol that they suggested: adequate hematocrit during cardiopulmonary bypass, adequate flow on cardiopulmonary bypass, and very importantly, and this is one of their contributions, they looked at oxygen delivery, and they felt there should be a minimum oxygen delivery on cardiopulmonary bypass. Now, I think this probably can actually, this type of rationale can be used in the critical care unit as well. But they look specifically, because you see, you have all those numbers available. You know what the cardiopulmonary bypass flow is. You know what you're at 100%, usually 100% oxygen saturation, and you have a hemoglobin you can control. So you can actually judge what your oxygen delivery is. So they in their results, and they looked at almost 17,000 consecutive patients, they were able to reduce their rate of AKI from 5.8 to 3.1% using a goal-directed perfusion protocol. This is for cardiopulmonary bypass. Now, actually, as I say, we were aware of this type of study, and at Johns Hopkins, we performed a study and looked at the lowest oxygen delivery on cardiopulmonary bypass and hypotension. And we found they increased the risk of AKI after cardiac surgery. And so what we found was that if the nadir O2 delivery on cardiopulmonary bypass was less than 225 ml per minute per meter squared, that there was a significant risk of AKI, 0.01 probability, and also pressure. We've talked about the importance of perfusion pressure, and this study showed it as well, that if the mean, and remember the number 60, we've talked about the number 60 here. So this is 60, mean arterial pressure less than 60, and for more than 15 minutes. We all know it can go up and down, but it was, we looked at it carefully. Over 15, it was longer than 15 minutes. That also had a highly significant p-value for the occurrence of AKI. So what are the latest management practices to prevent or decrease CSA AKI? Well, we can optimize the arterial and central venous pressure. Now, we talked about the importance of the gradient across the kidney. It's one thing to have a good mean arterial pressure, but if you have a marked elevated central venous pressure, the AV gradient across the kidney is unfavorable. So we keep that in mind. And then optimal oxygen delivery, the cardiac output, or if you're on cardiopulmonary bypass, the flow rate, and if necessary, using VAD and ECMO, the open chest protocol, to make sure there's adequate oxygen delivery, hemoglobin, we've talked about that, and as I say, arterial O2 sat. And if necessary, early renal replacement therapy. Well, you've heard about these authors, and I think, again, these are very important papers that have occurred. It's interesting how rapidly this field is expanding in terms of the research and the findings. This is an important paper from Mirsch and Alex Zarbach. And the point was the prevention of CSA AKI, the importance of maintaining sufficient perfusion pressure. And in the paper, in quotes, of paramount importance, early detection of AKI using the new biomarkers and adherence to the KDIGO guidelines. And also they mentioned consider remote ischemic preconditioning. So the challenge really is to recognize when the kidney is in an unfavorable environment, which if it continues will result in acute kidney injury. That's the challenge. Well, one way to talk about that is to say we're talking about when there is acute kidney stress. You probably know that Dr. Ronco joined me in writing at least an editorial about this, and we think it's a useful term, which is really based on all the molecular framework that we have learned about AKI. And it addresses the debate, what is the best term for the clinical phase preceding acute kidney injury? Now, as you know, over the years we've talked about it. We've talked about renal angina, and in fact, it's an interesting concept, but acute kidney injury is not associated with pain. There are non-ischemic mechanisms, and as you know, a variety of etiologies. So I think the renal biomarkers have been tremendously helpful in understanding AKI. And as you know, the cell cycle arrest biomarkers are released along the path which leads to AKI. And so it is proposed that this pre-injury phase, when the kidney is in an unfavorable environment, which would lead to injury, can be called acute kidney stress. Now, then the question is, are there diagnostic criteria? How could we then really pick this up very early? Because if we could detect early situations causing AKI, it would lead to early implementation of corrective measures. Now, I think we all recognize it's probably premature to define criteria for a diagnostic scoring system. And that would be very good. And we've already, heard about protocols and all that are addressing this type of question. But I think we can start to identify potential parameters for which we can define specific criteria. So if you just take a look at the research that I've been talking about and what we've heard about, one could imagine that one might be able to create a diagnostic scoring system based on criteria for blood pressure, urine output, oxygen delivery, and the renal biomarker elevations. And just as examples, one might use the pulse pressure across the kidney, the mean arterial pressure minus the CBP. One could have certain urine output criteria, for example, the 6-hour number we've talked about, or even urine output over 15 minutes, minute-to-minute urine output. Then we talked about oxygen delivery, the hemoglobin, the arterial saturation, and either the cardiac output or the flow, so at least we know oxygen delivery. And then finally, very importantly, as we've emphasized, the renal biomarker elevations. So what would we do? We can change hemodynamic management. We can adjust arterial perfusion pressure. We can adjust venous pressure. We can adjust cardiac output. These are the goal-directed hemodynamic management we've talked about. If necessary, we can use VADs or ECMO, and we can adjust or decrease the use of vasoconstrictors. And then also, if we know it's happening, it may be very appropriate, as we've talked about, to institute ultrafiltration or continuous renal replacement therapy over time. We can identify toxic pharmaceuticals, and we can use agents to decrease inflammation. We're going to talk further about this on Friday, about new technologies to address this. I just want to thank you for your attention. It's been a pleasure to talk with you and enjoy sharing ideas with you.